All right, I think our numbers have stabilized for a minute, so I am going to get us started. Welcome, everyone, and thank you for joining us for this panel discussion titled RAAM Clinic Care Experiences from the Field. My name is Kate Hardy, and I'll be supporting this session. Before we get started, just a couple of quick reminders. Firstly, the session is being recorded. And if you have any questions during the session, please enter them into the Q&A box that you'll find at the bottom of your screen. I'll then ensure that they get asked as our time allows toward the end of the session. You can also add comments to the chat box, but do please try and keep your questions for the speakers to that Q&A box, because that's where I'll be looking when it comes time to ask them. With that, I'm going to hand it over to Michael to start us off with some introductions. Thanks.
Hi, everybody. My name is Michael Roach, and I'm the clinical manager for regional outpatient addiction services at Health Sciences North in Sudbury, Ontario, and the regional lead for the Rapid Access Addictions Medicine clinics in Northeastern Ontario. I'm also a registered nurse with a varied background in education, nursing, regulation. Oh, I got a message that nobody can hear me. No sound. Can everybody hear me? Okay, some people can, some people can't. Perfect. So I have a varied background in nursing education, regulation, mental health, and community health. I'm going to be the moderator for the session today, and I'm going to read everybody's bios for you now, starting with Emily Dakers. Emily is the director of the Good Shepherd Barrett Center and Health and Wellness Programs in Hamilton, Ontario, and has been with the Good Shepherd for over 10 years. She is a social worker who has worked with many populations within the city of Hamilton, including youth, seniors, domestic violence survivors, and those experiencing mental health and addictions crisis. Her work is centered on harm reduction and EDI, and looks to increase access to holistic care for those who serve through effective program building and partnerships. Next is Tasha Meier. Tasha is the manager of the addictions medicine pillar of Stonehenge Therapeutic Community and has worked in the addictions field for almost 20 years. She leads with compassion, integrity, and commitment to client-centered practice. Tasha is passionate about supporting individuals on their recovery journey while empowering her team to deliver ethical, evidence-informed care. She believes strong leadership starts with creating a space where both clients and staff feel heard and valued. Outside of work, Tasha is a proud mom of 3 girls and helps support her family's sheep farm by feeding bottle babies and assisting in bringing home more animals for her husband to feed. For Tasha, leadership, advocacy, and nurturing extend far beyond the workplace. Next is Jason Perfect. Jason is the clinical supervisor of the peer support for Stonehenge Therapeutic Community, where he has been working since 2022. Drawing on his lived experience and professional training and peer support, Jason is committed to helping individuals navigate substance use and recovery with dignity, compassion, and hope. In his role, he supports and mentors his peer workers while continuing to advocate for recovery-oriented care that prioritizes connection, trust, and empowerment. Jason's work focuses on helping people develop healthy coping strategies, strengthen resilience, and pursue meaningful personal goals. Passionate about reducing stigma and expanding the role of peer support in health and community settings, Jason is an active member of the recovery community and strong advocate for systems that center lived experience in the response to substance use. Liz Kamler is the clinical team leader at Oasis, a low-barrier harm reduction-focused primary care walk-in clinic within Sandy Hill Community Health Center in Ottawa. Oasis hosts an embedded RAAM clinic supporting timely access to addiction care for people who use drugs. Liz holds a Bachelor of Nursing and a Master of Public Health from McMaster University. Her work has focused on mental health, substance use, and harm reduction across clinical, community, and research settings, including roles within Ottawa, Inner City Health, the Ottawa Hospital Substance Use Program, the Pinecrest Queensway Community Health Center ACT team, and research at the Royal. And lastly, but not least, Wendy Stewart. Wendy is the Director of Integrated Health Services at Sandy Hill Community Health Center. in Ottawa, where she provides strategic and clinical leadership across the continuum of team-based primary care services. Her portfolio includes the Health Services Program, delivering comprehensive family practice and chronic disease management, the OASIS Program, a low-barrier complex urban primary care model supporting individuals experiencing homelessness, substance use, and mental health challenges, including a rapid access addictions medicine clinic, and the Youth Health Clinic, which provides integrated youth-friendly care in partnership with the Youth Services Bureau. Wendy is a master's prepared clinical social worker with over 2 decades of leadership experience across hospital, community, forensics, and Indigenous health settings. She brings deep expertise in mental health and addictions, harm reduction, and social determinants of health, with a strong track record in program development, system integration, and policy advocacy. She is actively engaged in regional and provincial collaborations focused on overdose prevention and integrated care, and is recognized for advancing innovative, equity-focused models that improve access and community and outcomes for structural marginalized populations. Before we get started, I am going to share our disclosure slides. And then after that, I'm going to put away the PowerPoints and we're going to start a conversation. So on the slide, you'll see speaker relationship disclosures here. And next, conflicts of interest. And no one has any conflicts of interest to disclose. Okay. So now I'm going to, oh, I didn't share. Sorry. There we go. Apologies, I did not share. We're getting started. All right, perfect. Now I'm going to stop sharing my screen. Okay, I want to thank everybody for coming here today and spending their afternoon with us. So I'm going to get the ball rolling with some questions. I'm hoping that each of you can provide us an overview of your organization, where you are located in the province, and an overview of the geography and communities that you serve. I'm going to start with you guys in Stonehenge.
Hey everybody, big thanks to Medify for having us here today. Tasha and I are pretty excited to share our experiences, good, bad, and otherwise. And also, thanks to the truly daunting number of attendees who took time out of their day to come listen to this conversation. I'm stoked to have you here. So Stonehenge Therapeutic Community, or what I might refer to as STC, was founded in 1971 by a Guelph psychiatrist, Dr. John Dugan, who started a 10-bed facility on a small farm in Campbellville, Ontario. Over the past 50 plus years, STC has expanded to offer 45 residential beds. Makes up like the part of the program that we're most well known for, our therapeutic community. In addition to that, we've expanded to offer a wide range of community-based services as well, which include supportive housing that exists in 3 streams: transitional, long-term, and permanent. We have our integrated community and justice services pillar, which includes but is not limited to support coordination, court support, and Let's Grow Together, a program specifically for pregnant and parenting women. We also have our addiction medicine and withdrawal support pillar, which is most relevant to today's conversation, which is where our RAAM and DFD program sits. In summation, STC now has more than 150 staff, serves more than 4,500 individuals every year across Waterloo Region and Guelph Wellington, which covers a service area of nearly 3,000 square kilometers.
Thank you very much for that. We'll now move on to Emily.
Hi, folks, and I want to echo as well. Thank you to Medify for having us today. I'm here representing Good Shepherd, which is the largest provider of social services in Hamilton, which has over a population over 500,000. We also have programs in Toronto and Niagara, and we provide, as our CEO puts it, care from people's first breath to their last breath through a wide range of services, including shelters, case management, supportive housing, mental health and healthcare, addictions programming, and that includes the program that I'm here to speak about, our mobile community-based RAAM program. We exist largely in the downtown core of Hamilton, but not exclusively. And the majority of the folks that we're serving are actively or have historically experienced some form of homelessness, housing, mental health, or addictions. Thank you for having me.
Thank you very much, Emily. And now on to Wendy and Liz.
Hi there. Thanks so much for having us. We really appreciate everyone's time. So we are joining you from the Oasis Clinic within the Sandy Hill Community Health Center. Our RAAM clinic is fully embedded into our clinic that runs out of Oasis. Um, we are located in Ottawa, and we are the only community-based RAAM in the city. The other RAAM is at the Royal, which is a hospital-based service. Um, so all of our care with our RAAM clinic is embedded within our primary care model for people who are experiencing homelessness or precarious housing, are involved in sex work, or experiencing substance use or mental health concerns. Um, some things we know about our particular neighborhood within our K1N catchment area: we have one of the highest unattachment rates for primary care in the province. And we also know that the folks who come in for care tend to have a higher complexity score than the average folks who may be accessing care elsewhere. Um, that's a snapshot of where we're at.
I would say we also have a high in the community. We also have a high use rate for our EMS and EMR, or sorry, ER rates. So as a result of kind of the opioid crisis that's happening in the downtown core, we have an elevated use of ER and our EMS in the area.
Thank you very much. Okay, so thank you very much for sharing where you guys are located, your geographical area, and the communities that you serve. I'm wondering if you guys can paint us a picture of your RAAM clinic, what services you offer, and what makes your RAAM clinic unique. I'm going to start this time with Emily.
Thanks, Michael. Our RAAM clinic is a one-woman show. So we operate a nurse practitioner-led clinic with our incredible NP. Her name is Susan Cook. And through this role, Sue is able to use her full scope of practice to provide RAAM care to those who are accessing shelters, drop-in, supportive housing, or are living rough. In working with those experiencing homelessness or in temporary shelters, Sue is often providing not just RAAM care, but primary care, mental health care, case coordination, and whatever else the person in front of her might need at that moment. We're able to recognize that while this person is in front of us, it's really important to get whatever we can done in that moment, knowing we might not find this person again for some time. A large part of Sue's care is relationship building and finding out what is going to be the best fit for each individual. She really has to tailor her care for the folks that she's working with, who faced a ton of stigma and negative experiences with healthcare and maybe with RAAM care previously. We do what I call guerrilla medicine. So we are bringing the medicine to the people in the field, driving to wherever they might be, meeting in parks, meeting at Tim Hortons, wherever we can catch this person in need. And I think that is one of the unique pieces of the service that we provide, is that we are truly bringing medicine to the person, wherever that might be. Sue holds meetings in people's rooms, in shelter, in meeting spaces, in public space, wherever she can sort of pin this person down. And being a one-person show means that she gets to sort of be flexible and creative in the way that she provides care, the hours that she's working, and things like that. So that's our clinic in a snapshot. She does have access to some brick and mortar sites, but really it's considered a fully mobile program.
Very unique and interesting. Wendy and Liz, I'm hoping you can tell us what's unique about your program.
Sure. So just to kind of paint a picture of our location. So our RAAM clinic is within the same hallway as our Oasis primary care clinic. And it's a very small hallway. So we're quite close to each other all the time. There's honestly, we wish we had more clinic rooms, but we make do with what we have. So we're all working very closely. And we're pretty unique, and I would say very lucky to be literally across the hall from our CTS. Which, as we know, because of decisions, is no longer going to be able to function after June the 13th, which is a very stressful time for everybody. So right now, having all of those services in such a close location together really increases access for our clients and helps people engage and build relationships over time and develop trust, and then potentially access whatever kind of treatment services they might be looking for or interested in at that particular time. We know that within our clinic, we had about 1,200 unique visits last year. We have nurses, providers, both MDs and NPs, and then we can also connect to some other resources within our clinic, such as psychiatry, chiropody, social work, dietitian, diabetes specialist. We've got quite a few different things that are available within our center. And then, so we aim to always provide, walk-in same-day appointments related to substance use support, and that might include assessment, connection to other resources, treatment, other referrals, etc. Anything else?
All while they're receiving, having their needs met for complex care, including the increasing need of wound care that I'm sure that Emily, your colleague, may be seeing it in the community.
Thank you very much. Okay, Tasha and Jason.
Hi. Okay, so I'm going to give a little overview of sort of what makes our clinic unique and what sort of paint that picture. And then Jason, which he does so well, is going to give a little bit more detail of that, of the sort of ins and outs. So our RAAM clinic launched in kind provincially in 2017 at half a day a week. And saying that, our current state, we actually are open Monday to Friday, 9 to 4 with full NP access. We have 2 bricks and mortar clinics and a mobile van and a digital front door, which are open 5 days a week. Our clinics are open Monday, Wednesday, Friday in Guelph, and Monday and Friday in Fergus. So also what makes our clinic unique is that we have an NP-led clinic. So our NPs bring together like-minded other practitioners. We offer flexible sort of working options for NPs so that they can do dual roles, which brings great awareness back into our clinics, which is great. We are also lucky enough to have a lead NP who is also the lucky for us, the Medified nurse educator, Katie Dunham. So that allows us some first access to that brilliant mind. Our bricks and mortar clinic, one is in Guelph, which sits inside of our CHC, which is now our heart hub in Guelph. Jason will go a little bit further into that. And we have another bricks and mortar clinic in Fergus, which sits inside of a family health team, giving us good access to some of the rural population that we struggle a bit more to service.
I think that our service excels in a number of ways. I think our ability to connect to primary care withdrawal management programs, community-based withdrawal management services, are speak to our strengths. I think part of that is a reflection of the robust diversity of services that Stonehenge offers independently, but also that at least one of our RAAM clinics is housed within the Guelph Community Health Center, which is now the home of our local heart hub, which means we are right down the hall from the on-site pharmacy. We have the ID clinic, the legal clinic is there in the building, diabetes care, et cetera, like all of the complement of services found in that building. In addition to that, the counselors that staff our RAAM clinics are also the counselors that staff our Community Withdrawal Support Service, or CWSS. So there's a very easy continuity of care when a person is transitioning from a RAAM to the CWSS or vice versa. I think another highlight of our service is that we promote the continuity of care through inpatient admissions. Folks are able to quite easily access our digital service while away at a residential treatment facility. Not long ago, I was actually providing the in-person peer support at least one of these clinics, And I had a beautiful relationship with a fella who was away at treatment in a neighboring community, but would sign on regularly just to connect with the peer support component of our DFD and RAM service, which is decidedly pretty cool.
Thank you all very much for that summary of how your RAM clinics are unique. So seeing three different models and approaches, one where it's a one-man show, where it's, almost no physical location, them going out to see people, to being embedded into a primary care clinic, to then having a virtual that is supporting a lot of physical clinics as well as having physical locations in various places is very, very different. So hoping that we'll get lots of good questions related to different models. So the next question, and this time I'm going to start with Wendy and Liz. So can you provide a clinical picture of the clients you see and how your team interacts with them, including the flow through your clinic?
Sure. So our RAM clinic will support anyone on a walk-in basis related to their substance use. Our Oasis primary care clinic's mandate, and therefore who we tend to see more of within our RAM clinic, is for folks who are unhoused, precariously housed, involved in sex work, or with mental health or substance use issues. We are a very busy clinic. Our spots, we have walk-in available in the mornings and the afternoons, and often our spaces completely fill up. So we really have started to encourage people to come in early as much as possible, which is really distressing for all of our staff because we always want to be able to see as many people as we can. Everyone generally will see a nurse first and then a provider, depending on triage, their specific goals and unique situations. So how everyone, I guess, travels through the clinic is going to look a little bit differently, and it certainly might also involve coordination of other services such as social work.
And I think just to add further context to that, this is when we say the clinic is busy, like on average 20 to 25 people a day coming in, and they are coming in distress, right? So often they're coming in to see the clinic for primary care matters. And of course, deeply embedded in that is how can we provide you access to that addictions medicine should you wish. So again, it's about being as low barrier as possible, meeting that client where they're at. And I think just as well, we are only funded for 20 hours a week of RAM. And in the community in which we are currently embedded in, we've had to actually utilize that in-kind service of primary care to provide access to addictions medicine from 9 to 5. And so that's been making sure that all of our providers and nursing staff are well grounded, not only in the provision of primary care for this population, but also have grounding in terms of OAT startups, assessment, bridging. And so again, we've been able to do that in partnership with many fee-for-service colleagues who are experts in that area. So we're very grateful for the partnerships that we have internally, but as well as externally through the Royal Ottawa Hospital, through the Ottawa Hospital. We're really starting to establish some pathways to optimize meeting the needs of this complex community.
Thank you so much. Tasha and Jason.
Yeah, I can speak to the flow of our clinics. So in general, the flow, or what I call the order of operations for a person accessing Digital Front Door for the first time, is that they are warmly greeted by one of our amazing medical office administrators who welcomes the person to the service, creates their patient chart, and then flags any urgent needs to the rest of the team. Next, the person checks in with our peer supporter, who during a person's first visit helps orient to the flow of the program, answers any questions that may arise. Recognizing that not everybody shows up already familiar with peer support, we can take a beat here to talk about what it actually looks like in practice, what it means to be in a peer supportive relationship. From there, the peer supporter can begin to lay the groundwork for what may become an ongoing peer relationship that grows in future visits. Really, from the peer perspective, that first interaction is really about creating comfort, clarity, and trust. Following the peer part is the counselor, who's focused on providing a brief solution-focused interventions and completes the withdrawal assessments like a CWA or similar. The last chain, or the last link in this chain, of course, is our nurse practitioner, who does the actual medicine stuff, which is what a lot of people access the clinic for.
Which I think it gives a good overview. We work really hard to assure that no matter where they are, they can gain access, right? So low barrier. If they don't want to see counseling, see a counselor, and they only want to see an NP, we still encourage a check-in. We still encourage a check-in with a peer. It also allows to maximize our NPs. Because by the time it gets to NP, they kind of already know what the need is. Just to kind of give, I had pulled some data with one of the MOAs just around sort of a picture of substance use concerns that we're seeing in the clinics. Alcohol use disorder around 53%, stimulant use disorder 28%, opiate use disorder 44%, benzos 2%, and then cannabis 4%. And then amongst those, obviously, because that's more than 100%, are polysubstance users. And then 17% of that is also nicotine use disorder, which we also see. So it's just showing that like there's a wide, and I'll talk about this a little bit later around sort of like looking at more robust data and how we can sort of pull pieces of like, you know, where people are sort of on that continuum of care based on their substance use.
Thank you. Emily.
I apologize. I'm also having tech issues, so I've been popping in and out. So I'm here for now. Hopefully I can stick around. In our clinic, we are largely seeing folks who are using opiates who have been using for a long, long time. They've often not had any periods of sobriety leading up to our care provision and have many co-occurring issues related to their physical or mental health. Accessing Sue is as easy as giving her a call, sending her a text, or catching her when she's on site at your program. Most often, staff at these programs are catching Sue while she's on site, or sending her a message and asking her to pop over when she has time, which is often same day or within a day or two of that referral being provided. She tries to make it as low barrier as possible, obviously. So it can be as easy as, hey, Sue, we have somebody on site who is interested in seeing you. This is their basic concern. Can you pop over? And she'll give you a good timeline as to when she might be there. She's also often used as a support for the non-medical teams at these different sites for consultation, both for the patients that she's supporting and those that she's not, knowing that, our social work coworkers or social service workers, child and youth workers, things like that, may not have the same level of expertise, obviously, in the area of addictions, and particularly on the medical side of it. And so she is very often used for consultation and general supports as well, which is really great. So the flow is really dependent on who she's working with, what they need from her, and how frequently she might need to follow up with them afterwards. There are sites where she has weekly clinics set up. So for example, at our Tiffany Barton Outdoor Shelter Project, she is there every Tuesday, and she is busy every Tuesday with something like 35 of the 80 residents there, and has really, really high compliance. And then there's sites where she drops in as needed. For example, at the Barrett Center, which is our mental health crisis program, we will let her know, hey, we've got so-and-so on site. Can you come on by? And she'll try to do that as well. So really flexible in how she's providing care.
Thank you very much. So getting a little bit of an understanding of how your clinic flows and the population you see, how has the population you served helped you refine your unique RAAM model? And I'm going to start with Tasha and Jason this time.
Okay, thank you. So we have a large population that are rural. So this makes it more difficult to access service. Jason kind of mentioned some square kilometers earlier on today. So this does give where access is a barrier, anonymity also becomes a barrier when you're working in small towns. So in 2022 is when Stonehenge launched our virtual RAAM. So that's our digital front door platform, which has allowed us to expand access to services within those communities, not being able to access our Fergus RAAM clinic. Jason's going to talk a little bit more about that.
Yeah, like the immediate benefit of the digital front door service is that we're able to serve more people over a wider area in a way that is more easy for the people engaging in service. Like that was the initial like mentality behind it, and I think it really hit the mark on that. From my peer perspective, an additional like unexpected benefit or a way that we were able to utilize that development is that we can integrate RAAM care into hospital-based care as a component of our peer-to-peer program, which places peer supporters in our regional emergency departments. So through this program, our peer supporters can facilitate like bedside presentations to digital front door by bringing a laptop or a tablet, and thus like our full spectrum of service right to the person right when they need it. Like talk about meeting people where they're at. And we similarly have a parallel process at the withdrawal management service that our community utilizes.
Thank you very much. Emily, wondering if you can also answer the question.
Yeah. Our program exists concurrently with a brick and mortar RAAM clinic within Hamilton, which is run by one of our hospitals. Our program was built to serve those who weren't fitting the model at the existing clinic and perhaps don't have the ability to complete the follow-up or attend appointments, even in a walk-in basis, or leave their current spaces. And so our program operated really heavily in encampments when that was really happening in Hamilton. And so this program was built in response to ongoing community needs, even though we have quite a large hospital system, quite a large primary care system, and existing RAAM supports. It was recognized that there is this pocket of people who are not being reached by the existing services. And our nurse practitioner last year interacted with more than 300 unique individuals as one person throughout the year. And so I think that shows that obviously the need is there, and was directly in response to what we were seeing, especially as the large social service agency that we are. The people who were internal to our services we were seeing weren't making it to the follow-up or to the appointments at the brick and mortar RAAM. And so we wanted to make sure that we were able to build something that was serving the thousands of people that we serve every year already, and having it in-house and flexible and sort of in our mission-driven way.
300 unique individuals for one person is a lot of clients. That's incredible. Wendy and Liz, I'm wondering if you could also chime in.
Yeah, and it's funny, I'm actually also watching the chats, and I see there's lots of questions about who's funded for what, and how many providers. And I think a theme between all of us here is the fact that we're taking what little resources we have and stretching it to make it work. So full disclosure on our part, we are funded for 20 hours of RAAM. That is for an MP and for a portion of a nurse. That is it. And so we have taken our primary care resources and expanded it again just to, incorporate the rest of the other providers. So, we're fortunate enough to actually have had those resources to make that happen. I think that's number one. And again, also what is unique about us, we are brick and mortar. I think it's already been discussed. What's adjacent to us is a safe consumption site, as well as our mental health, our addiction services, access to ID clinics. But, we also have a respite kind of drop-in support that is a bit unique to us as well. So during the day, the needs in this community have exploded in terms of meeting unmet housing and social service and healthcare needs. So even for people to just be during the day, we've had to create a space. And on average, we see about 1,300 people in this small space a month, just receiving health promotional, HIV testing, dental care, a meal, even just a place just to be and not being pushed along by our local community and police services. In that, we also have the ability to have access to peers and community workers. And so one of the concerns for us is if the CTS, which is slated to close, what is the impact of that in terms of our current engagement abilities? But also even having access to the peer support that's funded through the CTS. So again, uncharted waters. I think the big thing as well that has really shaped our clinic is so many of our clients, as discussed, on average, 1,200 clients a year with multiple visits. 900 of those people have visits, more than 10 visits a year in that clinic, some 20, some 30, depending on what's happening in terms of their comorbid health issues. Again, we're seeing a significant increase in wound care, which slows the clinic down because of the care required, which then backs up the waiting room for people to access care. There's a lot of moral distress. But I think as well, being able to merge, resources to make it happen. We would love to do outreach, but if we actually pulled somebody out of our clinic to do outreach, it will just back up the waiting room. So the community, as well as outreach partners, the police, EMS, they often bring people to our door. The clinic's been there for about a decade now, and so it's well established. People know, and it's really located in the downtown core. We do have another partner in the area, CHC, that has on the west side of the downtown core that's opening up a low barrier primary care clinic, as well as Intercity Health and the Mission. So between a few of us, we make sure that if we can't see somebody from a primary care lens, we can help navigate those clients to get care. But from the RAAM portion, people often know that we are the place to be. I think as well, we do, we offer a lot of teaching. So a lot of nurses come through, nurse practitioners, providers, residents, specialists coming through. We're very fortunate to have partners, fee-for-service partners that bring their expertise. So again, I feel as a partner to this community, our duty is to also advocate, but where we can, I think we've done a great job with what little resources we have to provide an opportunity to build capacity for the future providers that come before us. I don't know, is there anything else I'm missing? Okay, great.
So I'm glad you talked a little bit about partnerships. We're going to come back to that in a moment. But first, starting with Emily, I'm wondering if you can describe your staffing model, how it evolved over time, and why it works for your RAAM clinic. I know your staffing model, you said, is a one-man show, so I'm curious to hear how that's evolved, why it's the case. I think there's a theme going on in the chat, like we talked about, related to funding, but I'm curious what your answer is.
Yeah, we've always been a small program. We have administrative support through myself and an office coordinator who I work with, but who is doing administration for all of the programs under my portfolio. And so there's no dedicated admin for this program. We were fortunate to have the opportunity to expand our services to 2 nurse practitioners. So it would be 75 hours a week. But unfortunately, we've had a vacancy for an extended period because our team is working at programs that have other supports and positions in place. We don't need to have it all internally, so we really rely on our partnerships, which we'll touch back on after, so I won't dig in too deep. But being such a small program, we really rely on those partnerships that we have to be able to do some of the other work that often happens internally at other programs, and so including peer support, case management, primary care, whatever that might be. But with our extended vacancy, unfortunately, it means that we are serving half as many people as we might otherwise be able to serve in our very tiny program.
So thank you for that. Part of my role in the Northeast is helping to support the RAAM clinics that we have up here, and nurse practitioner vacancies are a very common theme that we hear. Provider vacancies in general, having access to addiction specialists is huge. So I empathize with your challenge, and know that you're not alone in that challenge. Wendy and Liz, I'm wondering if you could also tell us a little bit about your staffing model and how it's evolved over time.
Sure. I mean, Wendy did outline already. So we're funded for a much smaller portion of RAAM services than what is realistically provided, and we do that in collaboration with the primary care clinic. So we have fee-for-service physicians, we have nurse practitioners, and RNs within our clinic. That all support RAAM, and some of our NPs are currently being trained to build their skills related to OAT services. We also we're very lucky to have access to what we have access to within our community health center. So, I mean, you mentioned the drop-in, the peer support workers. We've got excellent MOAs, psychiatry, dietitian, diabetes specialist, chiropody. These are all things that while they're outside of our clinic, but they are accessible, which is we're really lucky to have that.
Just to put things into context, again, and it's funny, somebody made a comment about admin support. We have zero admin support as part of the RAAM funding. So, like, there's 3 primary care clinics that I'm operating. So I'm just cannibalizing where I can. Under the radar a little bit, because of course, as we know in this current government, this is about attachment to primary care. So I'm taking some primary care funds and helping support not necessarily attachment for that low barrier need, but access. So it's dicey, but it's needed. And again, an unexpected thing that we have seen in the clinic is the need for wound care. It is so lower limb preservation. So oftentimes, we're doing all that health engagement, social prescribing, as well as engagement in terms of determining where people are at with their addictions while, administering care for that wound. So again, the nurses are magicians in terms of engagement. We will also keep people's medications at our site. And sometimes we see people run through, walk past the door, and our nursing staff will like run outside, and be like, okay, it's time for your IM, folks. So we're doing everything we can to engage people, but we don't have our MOAs are funded through primary care. And we, if you can believe it, have no social work. So in terms of our RAAM assessment, as much as we would love it to be very standardized and sitting people down, most of our clients, if not all, have little to no access to IT. So calling people back for appointment reminders, even digital front door is rarely an option for our clients. So really on-site services is where things are at for us.
Thank you very much. Again, another common theme that I regularly hear in working with other RAAM clinics is the utilization of in-kind supports. So you mentioned cannibalizing other access points. It seems like another common theme when we talk about RAAM clinics and them being underfunded and not having the resources that they need. So moving on to Jason and Tasha.
Yeah. I had a little rundown of what I was going to say, but then I changed my mind last minute. So very similar to the other clinics, we offer a lot of things in kind. So we borrow beg from other parts of our program to provide the wraparound care that we do. So as Jason had mentioned earlier about our community support service program, they operate in both the RAAM and DFD and community withdrawal management. So they hold a bunch of hats. Our MOAs, we do have MOAs that are part of our RAAM and DFD funding model, along with roughly 4 FTE NPs. However, just as any other clinic, sometimes can't secure having 4 at all times. We currently have one, two, three, four, five. We have 6 really great ones, all who do a different level of work with us, and one who's currently on a bit of a leave, which is hopefully she'll be back soon. So we are still able to support virtually and in clinic, whether it's virtually or in person by an NP, every day of the week for our full amount of hours. The one piece that we haven't been able to have is an NP on the RAAM van or a nurse on the RAAM van, which is a hope for the future.
Just before we move on, the peer guy really wants to highlight here that I'm told that our clinic was the first in Ontario to offer peer support as part of its core staffing model. This fills me with deep and sincere pride, despite it taking place years before my involvement with the agency. But just pure work, Thank you.
And knowing a bit about your peer program, I think it is something that you should be proud of, and that many RAAM clinics should strive towards. Moving on to partnerships now. Can you all please describe what partnerships have been essential to the development of your RAAM model? And we're going to start with Wendy and Liz.
So without partners, we would all be dead in the water. Not only internal partners, as you're hearing, all of us are having to do with our internal resources, but from an external perspective, I think, and I can only speak to Ottawa and the current opioid crisis. We sit as part of an overdose prevention task force. So the city has made this a priority. So we sit with many healthcare providers, community service providers, including, and I know, maybe this might be a topic, but we're seeing a growing need of the newcomer population, those that are uninsured, that are falling through the cracks, that are appearing to have opioid, addictions. And so I think that is, number one, I think a city-led priority, and subsequently it's really brought all of us together that have otherwise been drowning in this crisis. But I think as well, through the Ottawa Hospital, there are now substance use disorder pathways that are actually being created that are really helping streamline when somebody is accessing a clinic and going to emerge. It's helping facilitate streamlined access to information, as well as when people are coming from emergency rooms in the Ottawa area. This pathway is starting to help establish where do the emergency rooms actually divert people to, as well as jails. So we have a lot of partners, and again, the community-based partners that have been foundational. We have, Ottawa Inner City Health. I'm just losing my mind here, but OATC, Recovery Care. Those are kind of our traditional partners in the community that we've, worked together over years, as well as the mission. It also comes with some difficulties. So we don't share the same EMR. And so, we'll talk about that later, but it's amazing to have the partners. And Somerset West and Centretown Community Health Center also have low barrier clinics. But we also, again, a barrier is the community that we're serving are often so disorganized and trying to find housing, a safe place to stay for the night, even an alleyway, that they're often moving around the city, and so often touching multiple provider points. And not all of us deliver, safer supply. And so you've got some other, things happening where clients are getting, one type of addictions medicine somewhere and another type somewhere else, and not having an EMR. So it's amazing to have. And yet in the same light, I think there's lots of opportunity moving forward for all of us, to be able to centralize things to deliver optimal patient care. It'd be a dream. It would be a dream. Yeah.
Thank you very much. Jason and Tasha.
Yeah, we have, I think Jason might have touched on it earlier, where we have a lot of partnerships with Guelph. We sit in the CHC Heart Hub, so we have access and supports with a lot of the programming that runs in there. Historically, it would have been Safer Supply and our Stay Sharp and our consumption site, which was a huge benefit to our folks. Obviously, no longer, but have been implemented with lots of other care to help be alongside the care that RAAM provides. So like, for example, our ID clinics, they have an ID clinic, which is super helpful. We can just walk someone downstairs and they can do an ID application or get their birth certificate. The other sort of really great example of that is wound care. So again, we don't always have a nurse practitioner in office, but we can bring someone downstairs for wound care. Do you want to talk about hospitals, the peers?
Well, I just think like if we're considering like the development of our RAM model, and I recognize that I am taking like a hyper-focused peer perspective on this, but I do think a great deal of the like collaborative development and ongoing refinement for our hybrid RAM model has been the product of internal discussion and collaboration. Many of our programs across the agency have clients that regularly utilize our RAM clinics, including DFD, and thus we have to work in concert. So this includes the crisis stabilization program, our residential therapeutic communities, local hospitals and withdrawal management service, as well as the local heart hub in which one of our clinics resides. Interestingly, but maybe unsurprisingly, the one commonality of all of the programs that I just mentioned is that the presence and availability of peer support. Stonehenge has embedded peer supporters into everything that I've just mentioned and a bunch of other things as well. Our peer supporters facilitate connection to the RAM service. They support during appointments and generally promote ease of access to this valuable support in the context of like the whole spectrum of Stonehenge services.
Thank you very much. Emily.
Yeah. So I've mentioned that our RAM program is part of the Good Shepherd at large. And so when we were building this program, it was really important for our RAM to fit fairly seamlessly in with the sites that were already in existence, that were already serving the populations. And we're fortunate that having it be an internal process made that quite easy. And so we can have those direct conversations about how we can best prioritize the needs of the clients that are at those sites. However, as a largely non-healthcare organization, we've been really fortunate to be partnered with the Shelter Health Network here in Hamilton for 15 plus years. And they're a group of community-based physicians who are providing primary care in these settings similarly to our RAM care. And so we're able to rely on them for those low barrier referrals to primary care and follow-up. We also have a mobile health bus that works quite closely with our nurse, with Sue when they're able to. That includes a mental health worker, a peer. It includes nursing and wound care. So we really try to, even though we're a very small program, one woman show right now, we really try to ensure that all of the service that this person might need can be brought to them as needed. And Sue's able to facilitate those referrals quite easily because she can just call up Jamie, who's our mental health worker on the bus, or can just call up Liz, who's our peer with the primary care program, being that they're all internal services. And then our work with the Shelter Health Network has been so long-standing at this point that we have a really great relationship with them and are grateful to them all the time for the services that they provide. We also, within Good Shepherd, have several nurse practitioner positions. And so we're able to have a bit of a community that way as well, in partnership with the other nurse practitioners who are serving similar populations just in different roles. And so ensuring that there's a sense of community there so that we can, again, make sure that it's the most support for the most people. And then as new programs are coming up in the community, we sit on lots of different tables and try to ensure that we are able to be visible to the new programs that are coming up and to our partners in the community that are also serving the same populations, knowing that we can absolutely provide supports that otherwise might not be available.
Thank you so much. I have a question for all of you guys, as I've been asking questions. Obviously, I have more questions for you guys. But I'm hoping that you guys can explain to us what are some of the key successes you have experienced for your model. And I'm going to start with Stonehenge.
Can you start?
Yeah, again, like if I'm going to take the hyper-focused peer perspective on this, I recognize that success is something of a tricky thing for peer supporters to measure. Success for us isn't, it points to meaningful, supportive, authentic connections, not abstinence rates or treatment admissions or these other metrics that are easier to observe and measure. Success to a peer supporter is ultimately when a person feels supported. And I can think of a really beautiful example of this that's come into mind of a younger person who would frequently access the peer support component of our downtown Guelph RAAM clinic. This person didn't really connect too deeply with the counselor or the NP service there, but the connection to peer support was consistent and ongoing and for a considerable length of time. To make a long story short, this person received the support they needed to find appropriate housing. They went back to and completed college. They're now gainfully employed and with enough spare time to volunteer in the evenings. And again, it's not any of those significant life changes, which are all examples of kicking ass, to be real. It's not those that make the relationship successful, but that I know that that person felt connected and supported during that journey. Which is really different how some of you measure success, I recognize.
Yeah, and that's kind of why I wanted you to kind of lead, because I feel like my stats driven doesn't really hit the same way, right? I mean, I know that we need to do that for reasons for funding. And there's lots of good pieces we get out of collecting data and looking at that. And just kind of to give some examples, and I know some of you have already sort of touched on this earlier, but we service roughly around 710 unique individuals last year, and direct face-to-face around 5,200 in the last quarters or in the last fiscal year. So really sort of showing all of the great connection that the peers, counselors, NPs, and I mean, MOAs don't even count in that, but their connection with them, they're the first person they see, right? So there's lots of things that don't get captured when we pull data, that examples like Jason's able to provide gives a much clearer picture. And I think it even speaks to something that was said this morning. There was a picture around sort of relating to connection, right? And that sort of sums it up perfectly. So thank you.
Thank you.
Okay, wondering if Emily, you can tell us a little bit about some of the key successes for your model.
Yeah, one of the things we've been looking at is the volume of appointments as compared to the unique individuals. We know that the population that we're serving, they require more time and effort to make sure that that connection is built, that there's trust in place, that there is a willingness to engage with us. And so sometimes just seeing the person multiple times over a span of time is seen as a success compared to those that might drop off after initial consultation. So we really hold on to those folks that we can keep engaged in the service that we're providing. We also look at, is there a decrease in substance use? Are they more safely using? Are they changing to lower risk substances? These are all considered successes. And again, might not clinically on paper be seen as success, but something that we're definitely looking at. Again, these are folks that have been using substances for a long time without supports in place. And so any change is a good one in our books. We also have folks experiencing sobriety with RAAM for 30 days, 60 days, more time than they've ever had maybe in 10, 15, 20 years of substance use. And we want to ensure that we're celebrating that, absolutely, and that we're also celebrating somebody who maybe has 10 days of sobriety and is engaging and has come back for their second appointment. It's really important that we're looking at those things as well. And also, what other connections have they been able to build? We use the example a lot when we're talking about this program within the city of our new outdoor shelter program, temporary shelter program, where we've had hugely successful compliance rates among folks who had been not accessing shelter, had been living in encampment, who had been using substances intravenously for like years and years and years. And so to be able to have those folks be compliant on medications has been a huge success for us.
Thank you so much, Emily. Now, Wendy and Liz.
So I've been new to this role for maybe 6 or 7 months now, so I can speak to, since I've been here kind of on the more frontline level, what has been a really amazing ongoing success is the amount of interdisciplinary communication, and even beyond our team, cross-team communication. Everyone so clearly cares about the client, and it's really astounding to see over time and with client consent what can be built between different folks engaging with our clients. So whether it's CTS drop-in, if someone's just coming in to access clean gear, even the outreach team, if they say hello to someone out front, like over time we're able to start seeing people potentially more consistently and building relationships, building trust, as everyone else has mentioned here. And then offering care at whatever amount, or, at that moment, whatever they're looking for. So that's, I think, something that I feel we're very successful at.
And I think too, just the fact that, like, we also do client engagement surveys, do client engagement working groups with the CTS closure. Like, we're working with the community right now. What are your fears? What do you need from us and the community around to pivot? So again, I think there's a lot of advocacy work that we end up having to do on the side as a center. So again, our leadership team, even our board, all of a sudden is having to get involved in areas as a primary care community health center they didn't think they'd need to get involved in. I think as well, the number of people that we're able to see and not turn away is also a measure of success. And again, if we can't see you, we look forward to seeing you tomorrow. Where are you going? Can we get you a meal? Can we set things up for you? So set a plan up for tomorrow. And because we have so many partners, if something is truly that urgent, if we're short-staffed, it's lovely for us to be able to call one of our community partners and be like, listen, I want to make sure there's continuity of care for this community today. Somebody's called in sick, whatever. Guess what? Can we send our clients over to your shop? So I think that's another measure of success. All of us in the community are so resourceful in terms of making sure that, even one of our providers, who's comfortable doing this today isn't here, can I pop you over to the next place and just give you a call and set up a care plan or a pathway to get there? If that means I have to send you in a cab and I already know that my team member in one of my community agencies is waiting for you, we'll make that happen. So again, I think just like access to seamless care, if it's not through us on certain days, at least knowing that we can actually facilitate it within our community to make it happen.
Thank you so much. Switching gears now, I'm wondering for each of you what your biggest challenges have been through implementing your RAAM models, and starting with Emily.
For us, one of the biggest challenges, and I talked about this earlier, is staffing. So wage parity between hospitals and community-based care, and even family health teams compared to community-based model, it's not there. It's not there. And so especially looking for folks who are specialized in the work that they're doing, and being able to provide them with a salary that matches their abilities as compared to what they might be able to get in other settings has been a real barrier. I will say something that Sue has done a lot of work on, especially when she came on and was attending more encampments, was building connections with pharmacies as well. And so finding pharmacies that are willing to be creative in how they're providing care to people, be that going out into community and doing supervised doses and things like that at the shelter door, at the encampment. Even we had a pharmacy that's willing to go out and really sort of do the most in the community for people, recognizing that otherwise these folks won't be getting the care that they need. They're not eligible for carries necessarily, but we know that they will have the opportunity to be successful and be compliant and all of these other sort of hot words if the pharmacy is able to support us. And so with that work that's been done, that was a big challenge historically that we've been able to overcome a little bit over time.
Thank you very much. Wendy and Liz.
I would say that staffing is definitely a challenge. Between, I guess, staffing and the volume of clients that are requiring care is really the challenge. Trying to make sure that everyone is practicing to their top of their scope and that there are as many supports in place to get as many tasks done safely in the day as we can, but also knowing that staff burnout is a real risk, and there's also this moral distress if we're turning people away. It all becomes very difficult to balance all of these pieces. So definitely staffing, and then funding, as you've mentioned, continues to be a challenge, having to borrow from other areas and really make do with what we have. Even some of the technology pieces, I'm not sure if others have touched on this yet, but within our EMR, things like inbox management or labs coming in, since we are a primary care clinic and the RAAM is embedded, it can be a bit tricky to filter what goes where to make sure everything gets sent to the appropriate person. Anything else?
And full disclosure, there are times I'm just looking through, Medify's, survey and things that we're required to answer. And sometimes, full disclosure, I feel like we're failing in terms of providing adequate data. And I remember having a conversation with a colleague, and they're like, well, where are your clients coming from? Where are they referring? Where are you getting your referrals from? And I'm like, are you kidding me? They don't come in with referrals. They're coming in. We're picking them up off the street. They don't even know their names some days. So I think sometimes, the level of work and engagement to keep people alive right now, let alone tracking where they're coming from and how they're flowing through the system. And we're not able to do that because things are in such a chaotic state. And oftentimes I feel like we're not capturing the story well enough. And it is what it is, and know that we endeavor to do that. And if there's anyone on this call that is running a primary care clinic with a RAAM clinic embedded, I do know that there is that endeavor to create potentially an additional functional center where we're reporting. I would love to hear how you're all practicing, how we can come together and share, because clearly we're flying the plane and there's some spare parts that might be falling off on occasion, but we're also building it as we're flying it.
Building it while we're flying it, I think, is a good analogy for what a lot of us are going through. So I do appreciate your struggle, but I hope you don't think that you are underservicing the story, because it sounds like you guys are doing an amazing job. Jason and Tasha.
Yeah. So kind of echoing similarly around sort of staffing, especially when we are utilizing staffing from other programs, sick call-ins, that type of thing. Wage, obviously, and funding definitely play a factor in some of those. But I think the most, and correct me if you think I'm wrong, Jason, but I think the most piece that our biggest challenges is that we service such a large population and just a small city versus this really large catchment area where at any given time it takes an hour to get from one place to another. And there is no access to transportation. We don't have, touch points where people can do food banks and drop-in services and access to any of this sort of like care that we almost sort of take for granted in Guelph, because it's all situated in the downtown core and it's here and it's accessible and we can service people pretty seamlessly if they're wanting it. Where then we have this huge population of folks who, one of the examples that I was thinking of is, so our Fergus RAAM, if someone's coming from Mount Forest, it would take them an hour, almost an hour to get from Mount Forest to Fergus. And they would have to have access to transportation or access to some form of funding to get to the clinic. So that was why that Stonehenge, and this was historical to me, sort of launched the RAAM van. But that itself also came with challenges in the fact that not many people wanted to just like come up to a van that said RAAM on the side of it. Especially when you're in a small town and, the anonymity isn't there. So that's when we sort of pivoted a bit and started really working towards embedding peer support into other community resources like hospitals. We have peers in our rural hospitals, but also our counselors are outreach. So they can go out to folks, which works really lovely, not all the time. Even if they don't have access to technology, our counselors can go out, or our peer support can go out and meet them where they're at. We try to partner with, rural, like stomping grounds, right? Libraries, other sort of spots that our folks would frequent.
Well said.
Thank you so much. We have lots of audience questions, so I'm going to get into those, but I do want you guys to think about some key takeaways that you would offer to everybody. So I'm going to start with the first question from the audience. So how have CTS closures influenced referral patterns, volumes, and client complexity for RAAM clinics in your experience? And this is open to anybody.
Our CTS remains open at this time. Yeah. And on average, just for heads up, we see on average about 19,000 unique visits a year. So it is a huge, engagement opportunity for our RAAM and primary care clinic. So we're very curious to know, for those that have been impacted, what has it been? What can we expect?
So I can speak lightly on that. Prior to this role, I was actually working in the consumption site in our Guelph CHC, doing more frontline work, and the impacts are, there's no words to even describe it. The impact is horrible. I think there's lots of positive pieces that have come of it as well. Like, I don't think it's all negative, but the ability to have someone come in at the most vulnerable, raw state and just sit with them. There's so much work that can be done there. The access to healthcare that may not even have existed previously, wound care, right? The chances that someone's not coming in being like, I need wound care. We're sitting there, we're talking, and we're saying, hey, this looks like it maybe needs to be looked at. Can we get a nurse to come in and look at it? Right? It's those just natural conversations. And it works the same way with RAAM or any other clinics that are offering. It's the connection piece where you can naturally just have those conversations and bring someone to the clinic. Yeah.
One way that I see the transition to the Heart Hub model actually like manifesting in my community through this this lens of peer work is the scarcity or difficulty in accessing harm reduction supplies.
Yes.
So our team of peer supporters, where structures allow for it, have taken it upon themselves to bring that to the people that they support wherever possible. We have one peer who does like a rural outreach component solely covering 2,500 square kilometers of of her own sweat and perseverance. And in beautiful punk rock fashion are filling up backpacks full of clean needles and Narcan, etc., and bringing it to people who are unable to otherwise access clean, safe gear.
Okay. Oh, Wendy, I see your hand up.
Yeah, I just wanted to say, like, we are heart hubs. We have two in the area and that have just recently opened up. So again, I think just trying to figure out, they themselves in one area lost to CTS. So that heart hub in the kind of central west area in Ottawa is trying to address their immediate needs. So, knowing that we're in another area, getting people over to those heart hubs, which, by the way, the treatment and accessibility is needed, and, super important. So again, I think for us, we have yet to see what it's going to look like. Our team is very distressed right now in terms of, do we need to pivot as of June 13th for overdose response outside our building? What is that impact going to be, right? So even the team is looking at more life-saving measures in the next few weeks. And so I think that's part of a concern. We're working with the City of Ottawa to figure out a coordinated outreach strategy. Who can we partner with? But I think it's important for everyone here, and you're all living it. Everyone's living in such unique times right now. Everyone is morally distressed. And thank goodness you're all here. And it's nice for us to know that we're not alone in all of this.
Okay, I'm going to go on to the next question, unless anybody has anything else to add. 3, 2, 1. All right. So for all presenters, do you accept out-of-province clients? If so, how are they funded? And do you know of any similar programs to yours in Alberta?
I can say that we've been very creative with serving folks who have come newly to the province and are seeking supports or seeking addictions medicine. We've been fortunate that one of the pharmacies that we work with has an account that we've been able to put a small amount of funds into for folks that maybe are attempting to fill a prescription and don't have OHIP to cover it. And so we've been able to pay for some of those for a short period of time while items are sort of sorted out on that end. It would never be it. The person would have to be here, but we would never say, like, we will not serve you because it just requires, I think, an added level of creativity and money to be able to support those folks.
Thank you very much, Emily.
And because we are embedded in a community health center, part of our mandate is to ensure that people that are uninsured do receive some level of care. So whether you're a newcomer who has no primary care insurance, no OHIP coverage, we will certainly provide episodic access to primary care, and that would also include episodic care to, addictions medicine. And of course, because we have access to social work and good relations in the community, who do we need to partner with to actually connect that person either to theirs? And we're also, by the way, just on the border of Quebec. So this actually happens a lot, right? We're going to get people started, but then bumped back to where they need to respectfully be.
Thank you all so much. Wendy and Liz, this next question is specifically for you guys. So you mentioned wound care. Is this something you do through RAAM? If so, how are you offering this to clients?
So our RAAM is embedded inside a primary care clinic. So just by default, people are often coming to see the clinic for their health-related matters. And it just so happens that at the same time, we can actually offer you rapid addictions medicine. So I'm not sure if that answers it, but people are primarily engaging us for their primary care needs. And given that this is such a underserviced population that's facing so many barriers, they're having significant comorbid health issues. Does that answer? Hopefully that answers your question. We're doing it through primary care, a primary care team that I'm already funded for.
This next question has short forms that I don't know off the top of my head, so hopefully you guys know what it is. Are any of your RAAM clinics offering PREP or PEP?
Master?
Yeah, so yes, we do, again, similar to the last question about wound care. So through access to our primary care, absolutely. Folks who access our RAAM clinic could also access those things.
HIV, PrEP, STI, like everything.
Okay. How are you supporting folks using stimulants for everybody?
Who wants to answer first? How about we answer? Emily looks like she was having connectivity issues.
Yeah, I'm so sorry. I missed the most recent question there.
Um,
Oh, sorry, Michael, you
I
just
was off mute and then I remuted myself. So the question was, how are you supporting folks using stimulants?
So as a I'm as a non-clinical member of the RAAM team, I don't know that I have a direct answer to that, but I know that Sue is in attendance, and so she could potentially put something in the chat there for us.
Yes, we second that. If any of our NPs, a few of them are here, want to throw that into the chat, I think it would be best coming from them.
Fair enough. So this next question is specifically.
We can comment.
Okay, go ahead.
Sorry.
So for someone with stimulant use disorder, if they're accessing a RAAM clinic, in most cases, they would start off by seeing one of our nurses. They would complete an intake assessment, same as for any other visit, and that would assess their goals related to their stimulant use. Based on that, the nurse would have a conversation with the provider that's working that day to see what could potentially be offered. And then it's a lot more related, first of all, to what the client's goals are, but then also to more of like psychosocial supports, possibly referrals, community resources, a lot of potential for health teaching, harm reduction, those types of things.
The other thing I just wanted to touch base on is because I operate a few other primary care clinics that don't have rapid addictions medicine built in, what a privilege for us to be able to say to our primary care partners who are primary care physicians and NPs that are holding the responsibility of being the most responsible provider, not having this expertise, being able to put our hand up and say, you can consult with some of our providers that can help you actually manage the care. So I think that's the other thing that we're doing as well, that to try to help build the capacity of our primary care teams in the Ottawa region to support folks.
Okay, so we are getting into the last few minutes of the panel. So I just want to remind everybody that Kate Hardy has put the evaluation in the chat. So please fill out that evaluation. Unfortunately, we won't be able to get to all the questions because there's lots of questions, but I do hope that you can leave all of the audience, each of you, with a key takeaway you would like them to know about how you deliver care in your RAAM clinic and how that model has worked for you. So I'm going to start because Wendy and Liz, you are on my screen right now with you.
Do you want to?
We are happy to collaborate with anyone who has further questions. If we can, we're also very curious about how other people are doing this work. So this was a really great opportunity.
Yeah, I think for us, I think for all of you, what I'm hearing is we've all had to pivot. we've all had to scrape together resources and we're all doing things in kind. And so, again, the fact that this conference has occurred and what I'm hoping for is, again, and because we are a bit unique in the sense that we've got that primary care piece embedded, it's possible. Partnerships are possible. And looking forward to collaborating with anyone who is interested in making sure shared care and what that can look like in this current environment where this government wants us to attach. How do we have our nurse practitioners, MDs, fee-for-service providers share care? I think there's lots of opportunities here in terms of like sharing those wise practices. So looking forward, and thank you for having us here today.
Jason and Tasha.
If I could take this last opportunity to pound my peer drum one more time, I would say that the virtual setting, DFD or otherwise, does like lend itself very naturally to peer supportive relationships for a number of reasons. One is that people can connect from home, which is like the safest environment. I'm thinking of one individual who has all of the reasons in the world to be untrusting and hesitant to make new connections, but having the virtual component allowed this person to connect in their own time from their safe space over a camera instead of in an office that may have been like an insurmountable barrier at times. I think another benefit to peer support in this kind of virtual setting is that people can connect when they're not at home. Thinking again of that fellow who was able to like connect consistently while attending treatment in a different community. And then lastly, peer support works beautifully in the setting because people can choose to connect virtually or in person. Like there's some fluidity if we want to transition from virtual care to in-person care or vice versa. So a person connecting with the service like can balance the convenience of a virtual presentation with the more like in-depth connection of a face-to-face based on their needs in the moment. Peer support. Yeah.
So on that access, right? We're always open to doing things innovatively, doing things differently. What's going to work for the person, right? How can we get folks to care? So I think that's kind of.
Thank you so much. And now, Emily, you get the last words.
I was going to say, always have a snack and a bus ticket in your back pocket. Always have the things that you don't know that you'll need. Have socks, have underwear, have gift cards, have the things that are going to get the folks to come back to you again because you want them to spend the time and energy and you want to spend the time and energy with them. And you want to incentivize the fact that wellness is possible and recovery is possible. And getting people to come back for that second visit, that third visit are really important. And so finding ways to do that and getting funding added to your services to cover those sorts of things, to cover roles like peer support and administration and auxiliary supports, auxiliary items, program supplies, et cetera, is so key.
All right. Well, thank you so much to all of our panelists for such an incredible session. Thank you for sharing your knowledge, your expertise, your experiences. Thank you, Michael, for doing such a phenomenal job as a moderator. All of us are so appreciative. I also want to remind folks, thank you, Michael, for the plug earlier, that the survey link for feedback is in the chat. And last reminder is that there's now a roundtable networking session taking place from 2:15 to 2:45. If you go back to the main platform area and click on the roundtable networking button, that will take you to where you need to go. So my final thank you to everyone for today's segment. Really, really appreciate it.